Not ordinary fellow here again. So I got another page. I mean, I'm very popular and against Dr. PCP. So he's saying, Doctor, not ordinary fellow. I would like to follow up with that patient with breast mass on the mammogram. What you're gonna do? Of course, of course. I'm gonna help you, Dr. PCP. Don't worry about it. I'll take care of this patient. But I'm a very young fellow, so I need to review the case and I want to study a little bit more before I actually say anything to this patient. So, newly diagnosed non-metastatic breast cancer. So, this is actually the most common diagnosed cancer in the breast cancer. So when you think about the staging, most of the patients will not be metastatic. And we have to recognize that because it's a leading cause of cancer death in women. And a leading cause of death in women from 40 to 49. It will require a multidisciplinary approach with oncology, uh, breast surgeon, and radiotherapy being the three pillars of the treatment. So again, most patients are not metastatic, and the treatment will depend on the stage. Um, so we use the TNM and the TNM recently incorporated biomarkers, the ER, PR, HER2 that we talk about in order to stage the patient and proper treat the patient. So early stage. Um, after you did the staging of the patient and the patient is stage 1 or 2A, they are certainly early stage. There is a subset of patients in the stage 2B that are considered to be early stage. So patients with a T2N1 disease. Locally advanced cancers are patients with T3N0 disease. So that's a subset of patients with within the stage 2B. In patients with stage 3A and 3C. So up to T2 and 1, it is early stage. Anything over T3 and 0 will be locally advanced, including 3A and 3C. Patients with stage 4, meaning they are metastatic, they will have, of course, it will be less common, as I said previously, and it only represents 5% of patients at the initial presentation. So, early stage breast cancer, again, patients with stage 1, 2, and even stage 2B, uh, T2, and 1. So generally, early stage breast cancer can undergo surgery with lumpectomy or mastectomy, uh, and that will involve the breast and the regional nodes with or without radiation therapy, depending on the stage. Uh, and following the surgery, the definitive local treatment uh, the treatment, we will have the adjuvant systemic therapy, uh, and that will be offered based on the tumor characteristics, size, nodes, ER/PR, and HER2 receptor. So early stage breast cancer usually will, as a general rule, will go for surgery that can be a lumpectomy or mastectomy. Regional nodes surgery can be offered depending on what you're seeing on the tests, and then radiation can happen or not. And after that, we'll be offering adjuvant systemic treatment based on the receptors and the tumor size. So this is just a general concept for you to get used to how the treatment for early stage breast cancer is. So the breast conserving therapy, the BCT. What's that? So BCT is breast conserving surgery. For example, a lumpectomy plus radiation therapy. So it always has radiation therapy. So the goals of breast conserving therapy is to provide the survival equivalent of a mastectomy with a cosmetically acceptable breast and low rate of recurrence. So the same type of survival rate and recurrence with less invasive surgery. The successful breast conserving therapy requires complete removal of the tumor with negative margins, followed by a moderate dose of radiotherapy that will be used to eradicate any residual disease that you may have. Among women with operable breast cancer, randomized trials have demonstrated equivalent disease-free survival and overall survival between mastectomy and breast conserving therapy. However, since the time that these trials were conducted, progress has been made in adjuvant therapy, and more recent observational studies suggest that breast conserving therapy is associated with at least comparable survival to mastectomy, and even with improvement of survival in some studies. So if you do breast conserving therapy, you should be able to have the same results of a mastectomy. And there are enough evidence showing that, and it's something that we always have to keep in mind as oncologists. And who is not a good candidate for breast conserving therapy? So patients with multicentric disease, remember that we talked about that before. So we have the multifocal disease, which is usually in a duct, in a quadrant, and we have the multicentric, which is in lots of quadrants. So if you have disease in many quadrants of the breast, probably lumpectomy is not ideal. If you also have a large tumor size in relation to the breast, it's not a good option. And if you have the presence of diffuse malignant appearing calcification on the imaging, meaning diffuse, so probably you should have a mastectomy in order to get rid of all the cancer. And also in patients with a prior history of chest radiation, because patients with a breast conserving therapy will require radiation, and as a general rule, you should not do another radiation, submit those patients to another radiation therapy. Of course, if you're pregnant, because you're going to need radiation, and as we know, radiation is teratogenic and will cause harm to the fetus. And persistently positive margins despite of attempt of a re-excision. So you had the surgery and the mass were positive, so we tried to do it again. You should not do breast conserving therapy. Probably you should do a mastectomy. but I am a hem-onc fellow, not a surgeon, so I'll leave these discussions, of course, to the surgeon. For patients that are not candidates at the time of the presentation, and sometimes we can offer new adjuvant chemotherapy. So, as a rule, new adjuvant is prior to surgery, then you have surgery, and then you have adjuvant chemotherapy. So new adjuvant is given prior to surgery in order to shrink the tumor and maybe downstage the patient so they will be able to have a breast conserving therapy. And who should get mastectomy? Okay, everybody that cannot get breast conserving therapy. And for patients that prefer to have mastectomy due to cosmetic reasons, or maybe they have high risk of cancer, so they prefer to have prophylactic mastectomy. What about radiation? So radiation, so post-mastectomy radiation is indicated for patients at a high risk of local recurrence. So which patients are in high risk of local recurrence? Patients with cancer involving the deep margins. Pathologically involved axillary lymph nodes. So they have axillary lymph nodes, so meaning the disease is more advanced. So if chances of post-mastectomy radiotherapy is high, it's important to coordinate with the surgery, because it may affect the type of mastectomy that the surgeon will do and the choice of a reconstructive approach and the timing. So it's always important to discuss patients in a multidisciplinary approach. So the evaluation of the axillary nodes. So you have the axillary nodes. So the risk for metastasis to axillary node is related to the tumor size and location, the histologic grade, in the presence of a lymphatic invasion within the primary tumor. So it depends on the time, the size of the tumor, the grade of the tumor, and the presence or not of lymphatic invasion. The evaluation of the regional nodes depends on whether axillary involvement is suspected prior to surgery. So that's why it's important to do a good physical examination and really look into the presence or not of axillary involvement. So clinically suspicious axillary lymph node. So you had a patient that you clinically think that the patient may have axillary nodal involvement from the breast cancer. So pre-operative workup may include an ultrasound with FNA or a core biopsy to help determine the best surgical approach. So if you have a positive biopsy, you did the ultrasound and you have a positive biopsy, an axillary node dissection should be performed at the time of the breast surgery. So if you know that the nodes are involved, you need to do the axillary node dissection. If there is a negative biopsy, you don't need to do any workup prior to surgery. So no more treatment, no more testing. Patients should undergo sentinel lymph node biopsy, the SLNB, at the time of the surgery. So you did a physical examination, you saw a lymph node, or you saw the lymph node in the ultrasound or something like that. Then you order the ultrasound with FNA or core biopsy. Core biopsy is positive. Then this patient needs axillary node dissection at the time of the surgery. If the biopsy is negative, then you don't need to do anything else. And then the patient should have a solitary lymph node biopsy at the time of the surgery. Patients with clinically negative axillary examination. So there is no signs of axillary involvement of the breast cancer. So ultrasound is negative, and also your physical examination is negative. They should undergo sentinel lymph node biopsy at the time of surgery. Further evaluation of the regional nodes depends on the finding of the sentinel lymph node. So patients with negative clinical disease, I mean, they don't have any signs of axillary involvement, do the sentinel lymph node at the time of surgery. Patients with one or two pathological involvement of the sentinel lymph node may not require complete axillary node dissection. So 1 to 2, you may not need axillary node dissection, but patients with, you can treat that with radiation. But patients with 3 may need axillary node dissection, and of course that will cause more morbidity to the patient. This is best determined on the individualized basis. I mean, you have to look into the tumor size, the patient status, and comorbidities in order to offer the best treatment for this patient. The adjuvant therapy. So what's adjuvant therapy? So that's treatment after the surgery. So systemic therapy, so adjuvant therapy is a systemic therapy and refers to the medical treatment of breast cancer using endocrine, chemotherapy, or biologic therapy. Depends on the characteristics of the tumor. For example, hormone receptor positive patients benefit from the use of endocrine therapy. Patients with HER2 positive cancers benefit from HER2 directed therapy. So in patients with early stage breast cancer, so stage 1 and 2 and some subsets of stage 2B up to T2N1, adjuvant will depend on the characteristics of the patient, of the tumor, and the preference and the performance status. The hormone receptor positive breast cancer should receive endocrine therapy. And they should receive endocrine therapy, and if adjuvant chemotherapy will be added, that will depend on the patient's and the tumor characteristics. I'm just talking about the general sense, okay? So adjuvant chemotherapy. Typically, chemotherapy is offered for patients with hormone positive cancer with high risk. So they are ER/PR positive, and they have high risk characteristics, as for example a high grade tumor, and this is a large size, over 2 centimeters, overall equal to 2 centimeters, and they have pathologically involved lymph nodes and a high 21 genes recurrence score, which is like a test that you do in the tumor. And if the high 21 gene score recurrence score is over 31 or equal to 31, then sometimes you offer adjuvant chemotherapy. So high grade, over 2 or equal to node involvement, and high 21 gene recurrence score over 31. So adjuvant chemotherapy, ER/PR, HER2 negative. So the famous triple negative breast cancer, which is the minority of the cancer, but is still significant. So adjuvant chemotherapy is given if the tumor size is over or equal 0.5 centimeters. Very small cancers will receive adjuvant chemotherapy. Those patients are not candidate for endocrine therapy because they are ER/PR positive, and they cannot also receive HER2 directed agents because they are HER2 negative. They don't have the overexpression of the HER2. So chemotherapy is pretty much their only option of adjuvant treatment. So that's why we offer, and that gives them small but still significant overall survival benefit. So adjuvant therapy, chemotherapy again, HER2 positive breast cancer with a tumor size over 1 centimeter should receive combination of chemotherapy plus HER2 directed therapy. So HER2 positive they are overexpressing HER2. If the tumor is over 1 centimeter, then you should do combination plus HER2 directed treatment. Tumors that are equal or less than 1 centimeter, it's more controversial. So probably the experts will have to decide in tumor boards. Following chemotherapy, patients with a ER/PR positive disease should also receive adjuvant endocrine therapy, but most of the physicians would not do endocrine therapy while the patient is in the chemotherapy. Okay, so ER2 positive over 1 centimeter should, HER2 positive over 1 centimeter should get chemotherapy. So locally advanced breast cancer, again, the approach is multidisciplinary. So the cancer will be T3, at least T3 and 0, and even 3 stage, but not 4, of course. So the approach is multidisciplinary. For most patients, the recommendation is neoadjuvant chemotherapy rather than endocrine therapy. So usually you will try to do some neoadjuvant chemotherapy to try to help this patient have surgery. So HER2 directed agent, the trastuzumab, should be added to the chemotherapy for patients that are HER2 positive. I mean, they are overexpressing HER2. For select patients with a hormone positive disease, neoadjuvant endocrine therapy may be appropriate. So if you are HER2, probably you need to have chemotherapy with HER2 inhibitors like the direct agent trastuzumab. And as a general rule, you don't do neoadjuvant endocrine therapy unless this patient doesn't have performance status to get chemotherapy. That it is for locally advanced breast cancer. So locally advanced breast cancer, again, following surgery, you had surgery without or with systemic therapy, meaning neoadjuvant chemotherapy. All patients should have that had a breast conserving surgery, for example, lumpectomy, they need to have radiation therapy because that will maximize local regional control. So local regional recurrence will be lower. For patients that were treated with mastectomy, so they did not have a lumpectomy, they had mastectomy, they should receive radiation in some occasions. So when you think about that, you have to look into the original pre-treatment stage, regardless the pathological response to the neoadjuvant therapy. That being said, what you have to think? So you don't look into the results of the surgery. So after you had the surgery, you have the pathological stage, And that's not the one that you have to look into when you order the radiation. So when you order radiation, when you prescribe the radiation, you should look into the treatment stage, the clinical stage of this patient, not the YPTNM. Okay? So patients that received neoadjuvant chemotherapy. So um, yeah, they had neoadjuvant chemotherapy in surgery, and what we're gonna do later on. So if they are ER positive, ERPR positive, meaning hormone receptor positive, they need to receive adjuvant endocrine therapy. So the endocrine therapy choice is made in according to the menopausal status, and I will do a video about that. It's not that complicated. So the hormone negative breast cancer should not receive further treatment provided they completed the planned neoadjuvant chemotherapy. So you have a locally advanced patient that got neoadjuvant chemotherapy surgery. Then what you're gonna do? They are ERPR positive, sorry, negative. So they should not get hormone therapy because they are negative, but they also should not get more chemotherapy unless they did not receive the full treatment for any reason. If patients did not complete planned neoadjuvant therapy prior to surgery, they should receive further chemotherapy in the post-operative adjuvant setting. Okay, so that's it. So patients with HER2 positive breast cancer, they are HER2 positive breast cancer, they should receive 1 year, one entire year of trastuzumab following completion of surgery. So after surgery, 1 year of trastuzumab adjuvant. Okay, thank you. And neoadjuvant endocrine therapy. So patients treated with neoadjuvant endocrine therapy who undergo surgery should continue with endocrine therapy in the adjuvant setting, whether or not to administer adjuvant chemotherapy is individualized. Some patients with a ER positive breast cancer in home surgery is not an option, or the life expectancy is limited. Primary hormone therapy with either tamoxifen or aromatase inhibitor, also known as AI, without surgery can be used. So you have a patient with a locally advanced breast cancer that has many comorbidities and cannot have surgery. So you can do neoadjuvant, although you're not planning to do any surgery, then you can do endocrine therapy. And also patients treated with neoadjuvant endocrine therapy should receive that got surgery should continue with endocrine therapy. That's not a very common situation though. So this is kind of an overview about the treatment of breast cancer. Of course, there are many subsets of patients, and there are many clinical trials, and we'll talk about that later on. And we're gonna keep an eye on the metastatic disease too, so I'll make a video about that. Please, if you like, subscribe and like the channel. I'll be doing that those videos because I'm learning and I want to record all this learning. So keep in touch. See you guys.